Good morning. Today we are going to discuss the topic of shock. Shock is a state of systemic low tissue perfusion that is inadequate for normal cellular respiration to happen. It is one of the most common cause of death in surgical patients. Death in cases of shock may be early if the shock is severe or profound, and it may be delayed due to organ ischemia and what is known as reperfusion injury. In condition of shock due to low tissue perfusion, there is decreased availability of oxygen and glucose to cells. As we know, the metabolism of cells is dependent on oxygen and glucose inside the cells. If these are depleted in cases of shock, it leads to a change from aerobic metabolism to anaerobic metabolism. It means from oxygen dependent to oxygen independent, that is anaerobic mode of metabolism. Now coming to the pathophysiology of shock, I will come to the various causes of shock later on. Coming to the pathophysiology of shock, at the cellular level, in cases of shock, there is decreased oxygen and glucose in the cells, and the metabolism goes from aerobic to anaerobic metabolism, and there is resultant production of lactic acid as a result of which there is increased lactic acid in blood. This all leads to systemic metabolic acidosis. As further shock ensues, cellular glucose is exhausted and even the anaerobic respiration also stops, as a result of which it leads to the failure of the sodium-potassium pump in the cell membrane and intracellular organelles, resulting into the release of autodigestive enzymes from the lysosomes, that is intracellular organelles which are storing the enzymes. They are released, and as a result the cell lysis happens and intracellular contents are released into the blood stream, and the level of ions like potassium etc. increase in the blood. Now at the microvascular level, in cases of shock, tissue ischemia happens and there is hypoxia and acidosis. This activates the complement system as well as the neutrophils and leads to the generation of free radicals, and also cytokines are released and they injure the capillary endothelium and activate the coagulation system as well as the immune system. The injured capillary endothelium, this activates the coagulation system as well as the immune system. The cardiovascular effect of shock is, as in case of any other low perfusion state, there is decreased preload and afterload. Preload means whatever fluid is returning to the heart, and afterload means the pressure that is there against which the heart has to work. So there is decrease in both preload and afterload as a result of volume depletion, as a result of which compensatory baroreceptor response takes place. This compensatory baroreceptor response leads to increased sympathetic activity and release of catecholamines, and these catecholamines cause tachycardia and systemic vasoconstriction. This leads to increased heart rate, tachypnea and increased vasoconstriction. Now coming to the respiratory part of the respiratory pathophysiology changes, the metabolic acidosis as a result of increased lactic acid production leads to increased sympathetic response, and this leads to tachypnea, increased respiratory rate and minute ventilation. This leads to increased excretion of carbon dioxide as a result of increased ventilation. This leads to compensatory respiratory alkalosis. So there is a change from metabolic acidosis to compensatory respiratory alkalosis. As far as the renal changes are concerned, the decreased perfusion pressure leads to decreased GFR, that is the glomerular filtration rate, and there is decreased urine output and resultant activation of the renin-angiotensin aldosterone system or axis. This leads to vasoconstriction and increased reabsorption of sodium, ion and H2O, that is water, by the kidney. These are the two effects as a result of activation of the renin-angiotensin aldosterone axis or system. As far as the endocrine effect is concerned, it is the same. There is activation of adrenal and renin-angiotensin aldosterone axis, and this leads to vasoconstriction and increased cortisol release as well, which leads to increased sodium and water reabsorption by the kidney. Now, in cases of shock, there is also ischemia-reperfusion syndrome. When we treat the shock, there is reperfusion to the end organs, as a result of which certain toxins are released into the blood, which damage the end organs. So here it is explained like how it happens. The systemic hypoperfusion leads to tissue hypoxia and local activation of inflammation, and there is increased tissue level of hydronium and potassium ion, which leads to myocardial depression and further hypotension. There is complement neutrophil activation, and there is formation of microvascular thrombi, and when there is reperfusion, these microvascular thrombi and toxins are flushed back to the circulation, and further endothelial injury ensues. Now coming to the classification of shock. There are various causes of shock, and depending on them, they have been classified into hypovolemic shock, which is obviously due to decreased volume, intravascular volume; cardiogenic shock, which is due to reasons centered in the heart; obstructive shock, distributive shock, and endocrine shock. Besides that, hypovolemic shock has been subdivided into hemorrhagic and non-hemorrhagic shock. Hemorrhagic shock means any bleeding, external or internal happening due to injury to the vital organs inside the abdomen, like liver, spleen, aorta, or many other organs, gut injury, and open external wound. They all lead to hemorrhagic shock. And among the non-hemorrhagic causes are dehydration, excessive fluid loss due to diarrhea or anything, vomiting, and third spacing, which is usually seen in cases of pancreatitis among surgical causes. Coming to hypovolemic shock, the reduced circulating volume is caused by either hemorrhagic or non-hemorrhagic reasons, and this is the most common form of shock. Next is cardiogenic shock, where the heart fails to pump the blood, and the reason lies obviously in the heart, and the reason may be either an AMI, post-AMI, arrhythmia, cardiomyopathy, myocardial depression due to any medication or any endogenous or exogenous agents. Even bacterial toxins may lead to myocardial suppression or depression, and exogenous agents like medicines cause myocardial depression too. Obstructive shock is seen in cases of cardiac tamponade, tension pneumothorax, massive pulmonary embolism. The reason being decreased preload or decreased return of blood to the heart due to mechanical obstruction to cardiac filling. Decreased preload is the reason in cases of obstructive shock. Now, the next cause is distributive shock, which is seen in septic shock, anaphylaxis, and neurogenic shock is also an example of distributive shock. Spinal cord injury, these are all examples of distributive shock where there is vasodilatation due to the mechanism involved in the respective etiology and leads to distributive shock. Now coming to shock due to septic foci, sepsis. But before I go to sepsis, you must understand what is systemic inflammatory response syndrome, that is written as SIRS in the books, and basically this is the manifestation of inflammation anywhere in the body, which may be an infective cause or a non-infective cause, and it manifests usually by hypothermia less than 36 degrees centigrade or hyperthermia more than 38 degrees centigrade, and manifestation is also in the form of increased T cell count, increased count above 12,000 WBC per cubic millimeter or less than 4,000 WBC per cubic millimeter, and also in the form of decreased arterial pressure, mean arterial pressure, etc. So there are 2 or 3 criteria. If these are fulfilled, the SIRS term can be used. Now, if there is a documented infection with SIRS, it is known as sepsis, and if there is end organ involvement or injury to the end organs due to this sepsis, it is known as septic shock. And here we are dealing with septic shock. Shock due to septic foci may be due to gram-negative or gram-positive organisms, bacteria, and rarely due to fungus, viruses, and protozoas. Now, coming to one of the most important topic, endotoxic shock, that is gram-negative shock. It is commonly seen in surgical cases where there is strangulated hernias, peritonitis, pancreatitis, biliary infections, urinary infections or urosepsis, diabetic wounds, or crush infection or crush injury. Now coming to the severity of shock. Depending on the severity of shock, it can be classified into either compensated shock or decompensated shock. Decompensated shock is either mild, moderate, or severe in type. Compensated variety, as its name suggests, with progression of shock, there is decreased flow of blood to the non-essential organs or non-vital organs such as skin, muscles, and the blood is diverted to the vital organs such as the brain, lungs, and the kidneys, which are vital for our survival, and the blood flow to these organs is preserved. So, in cases of compensated shock, the only sign may be tachycardia and cool peripheries, and as there is decreased perfusion to the skin, muscle, and GIT. Now, compensated shock is seen in when there is up to 15% of loss of the circulating blood volume. There is reduced flow to non-essential organs. Now, the compensatory response of cardiovascular and endocrine system is like tachycardia, peripheral vasoconstriction, increased circulating level of catecholamines. There is no obvious clinical sign of hypovolemia, since it is taken care of by the increased activity of the cardiovascular system and the endocrine system, and there is preserved preload and flow to the lungs and brain. So that is compensated shock. Now coming to the decompensated shock. When there is loss of blood or body fluids more than 15% of what is there in our intravascular compartment, the compensatory mechanism fails and there is decompensation of the renal, respiratory and cardiovascular system. So their function is decompensated or compromised. And among decompensated shock, this mild shock, we find that the peripheries are cool, there is increased heart rate, that is tachycardia, increased respiration, that is tachypnea, BP is maintained but there is mild decrease in urine output and the patient suffers from anxiety. So the symptoms are there, although subtle in nature. Moderate shock, the renal compensatory mechanism fails. The urine output becomes less than 0.5 ml per kg per hour and the BP also decreases, leading to drowsiness and mild confusion. So that is moderate shock. Severe shock. When there is in severe shock, we find that there is profound tachycardia and hypotension. The urine output is almost zero, so there is either oliguria, severe oliguria or anuria. Urine output may be zero and the patient becomes unconscious with labored respiration. So there is profound tachycardia and hypotension, urine output is almost zero and the patient is unconscious. So the cardiovascular system, the renal system and the brain as well as the respiratory system all are compromised. The next step is unresuscitable shock and multi-organ failure. However hard you try at this stage, the patient may not be resuscitable and the organs fail. Now I will come to the discuss in detail a little bit about the characteristics of septic shock, because this is very common in our surgical practice, and the characteristics of septic shock are systemic vasodilatation and hypotension, tachycardia, depressed contractility of cardiac muscles, vascular leakage as a result of endothelial damage, edema, hypovolemia. There is compromised nutrient flow to the organs, DIC, that is disseminated intravascular coagulation, acidosis and multi-organ failure. So everything has been explained in the previous part. So ultimately it leads to end organ damage, DIC, acidosis and multi-organ failure. Again I will highlight the pathophysiology of septic shock. Toxins and endotoxins, there is cellular inflammation and activation of the macrophages and monocytes which release cytokines like interleukin 1, etc. and free radicals. There is chemotaxis of cells and there is endothelial injury and altered coagulation cascade, and what I had explained just a few minutes back about the SIRS, that is systemic inflammatory response syndrome, ensues. And after that there is hyperdynamic circulation or hyperdynamic stage, where there is tachycardia, tachypnea, to counter the effects of shock in the early stages. This hypodynamic stage goes from manageable to unmanageable stage, so it becomes irreversible stage, and there is severe circulatory failure with MODS, and already I have explained that there is failure of kidney, lungs, liver with DIC, and acidosis is there along with sometimes compensated respiratory alkalosis. Trigger for endotoxic shock, for in cases of gram-negative bacteria it is lipopolysaccharides or the LPS in short, and gram-positive bacteria it is lipoteichoic acid, cell wall muramyl peptidase. In some super antigens are there like in cases of staphylococcal infections, toxic shock syndrome toxin, and in streptococcus infection, pyrogenic exotoxin, which is known as SP in short. So these are the various trigger factors or toxins which are released by bacteria and lead to shock. Now in short, I have given a flow chart over here where the gram-negative organism is releasing LPS, that is lipopolysaccharide, acting on the macrophages and leads to production or release of interleukin 1 and tumor necrosis factor alpha. These are called the first degree mediators of shock. And gram-positive organisms, they via gamma interferon and exotoxin lymphocytes, they act on the endothelial leukocytes. Molecular activation happens and they lead to release of second degree mediators, that is nitric oxide, platelet activating factor, leukotrienes and interleukins of other type. So there are first degree mediators and second degree mediators which are very important, and they lead to the effects like vasodilatation, capillary leak, endothelial damage, and which leads to septic shock and multiple organ dysfunction syndrome, leading to multi-organ failure ultimately. Now coming to how to monitor the patients of shock. Monitoring of patients of shock, there are certain minimum investigations which are a must for monitoring a patient of shock while we treat the patients of shock. First is blood pressure expressed in millimeter of mercury, urine output, which is very important for the monitoring the kidney perfusion, renal perfusion, ECG to see any cardiac changes which happen due to the various toxins released into the blood due to cell lysis and end organ damage, and also other products. Pulse oximetry, that is the oxygen saturation expressed as percentage and written as SpO2. These are the minimum parameters which should be monitored in patient of shock. Additional factors which should be monitored are CVP, that is the central venous pressure to assess the volume, intravascular volume, invasive blood pressure monitoring via an arterial line, cardiac output useful in patients especially with cardiogenic shock, and base deficit and serum lactate. Now what is base deficit and what is base excess? I must explain. Serum lactate, I have told that there is a increase in serum lactic acid level in cases due to anaerobic metabolism in cases of shock, and there is base deficit, that is decreased bicarbonate level. Decreased bicarbonate level is expressed as base deficit, and if in certain conditions there is also base excess, that is called base bicarbonate excess, that is known as base excess. Now we are here concerned about base deficit and serum lactate. Coming to the CVP. CVP, some patients require a CVP of around about 5 centimeter of H2O, and others may need a CVP of 15 centimeter H2O or more for as preload, it is an indicative of a preload, and CVP is a poor indicator of preload, but it should be monitored, and usually our goal is to keep the CVP above 8 centimeter of H2O. If it is less and if there is hypotension, we should give a bolus fluid. I will come to this later on about how we manage the fluid in cases of shock, and if there is high CVP, it indicates high preload and there is chance of cardiac insufficiency or volume overload. Now coming to the management of septic shock, we must know certain criteria of severe sepsis before managing a patient of septic shock. Severe sepsis is defined as sepsis induced tissue hypoperfusion or organ failure as any one of the following due to the infection may be present. Sepsis induced hypotension, that is the systolic blood pressure less than 90 millimeter of mercury or a mean arterial pressure less than 65 millimeter of mercury, lactate above its upper reference level, urine output less than 0.5 ml per kg per hour after 2 hours of resuscitation by a crystalloid, acute lung injury, creatinine level which is indicative of renal function more than 2 milligram per deciliter, bilirubin level more than 2 milligram per deciliter, platelet less than 1 lakh per deciliter, and international normalized ratio of more than 1.5. Now, during sepsis resuscitation, the initial management should be to administer crystalloid for hypotension, administer broad spectrum antibiotic, obtain culture depending on the site of the infection prior to starting an antibiotic if possible, measure blood lactate level. So these are the first 4 things which we must complete within the 3 hours, initial 3 hours. So this is the initial resuscitation. To repeat, we must administer crystalloid, we must administer broad spectrum antibiotic, culture we must take, and serum lactate level or blood lactate level we must measure. Both we have 2 groups of volume, to replenish the lost volume in cases of hypovolemic shock especially or septic shock. We have choice between crystalloids, colloids and blood. If it is a hemorrhagic shock, we have to arrange blood, but in the time when the blood is being arranged, we should give crystalloids. Crystalloids actually can have the capacity to cross the vascular border or the endothelium. So crystalloids, they can cross the intercellular boundaries, and colloids do not cross. But both crystalloids and colloids, they do not have any oxygen carrying capacity. So it is only blood which does this function, and in cases of hemorrhagic shock, when blood is lost, we have to give crystalloid till blood is available. Now dextrose is a solution which is a poor volume expander. It is a hypotonic solution. We must try to use hypertonic solutions. Crystalloids are exemplified by normal saline, Ringer's lactate, Hartmann solution and others, whereas colloids are dextran, hemaxil, etc. etc. Now, what is dynamic fluid response? Response of fluids, 200 or 500, up to 200 to 500 ml of fluid is given over a period of 5 to 10 minutes, and the patient, if responds, then it's okay, the patient is stabilized. And transient responders are those who have a moderate ongoing fluid loss. Non-responders are those where there is persistent ongoing bleeding and the response is not at all present, not at all seen. So either they are responders, transient responders, or non-responders. Coming to the various effects of multi-organ failure which is seen in cases of shock. Lungs is affected and it leads to ARDS, that is respiratory distress syndrome, acute renal injury, AKI, or acute renal failure, coagulopathy and cardiovascular failure. These are the various effects of multi-organ failure in cases of shock. Besides fluid, we can give vasopressors and inotropic support also. Vasopressors which are used are usually phenylephrine or noradrenaline, which are used in especially in cases of distributive shock, like in cases of sepsis or neurogenic shock. Cardiogenic shock, where there is decreased cardiac output, we use dobutamine, which is a inodilator and the agent of choice. In certain cases, we also use dopamine, but its use is less. Now, how to monitor a patient of shock? Now, I was discussing about the resuscitation part. The fluid therapy, IV access and IV fluids, they are usually delivered by short and wide bore cannulas or catheters. In certain cases of shock, like in cases of burns, we use central lines, or venesection we have to do peripheral cut down of veins, which is done in cases of long saphenous vein near the ankle, or other wide bore vessels are accessed. Now, the types of fluid I have already told that the crystalloids we use like NS, RL, that normal saline, Ringer's lactate, Hartmann solution, and among colloids we use albumin, dextran, etc. But the disadvantage of colloids is that they cannot cross the barrier, and that is the vascular barrier compartment, and they are more costly and they have more side effects too. Now, coming to the systemic and organ perfusion. Before I start the systemic and organ perfusion, I must tell here that the broad spectrum antibiotics which we use in cases of shock are usually should cover both the gram negative and gram positive infections, and we have a wide variety of penems and penicillins and piperacillin, tazobactam like antibiotics, which we use depending on our clinical judgment, initially for 3 to 5 days, and after 3 to 5 days, when the culture report is available, we give specific antibiotic therapy which should be continued for further 7 to 10 days to contain the infective part of sepsis. Now, coming to the systemic and organ perfusion, goals of treatment of shock. The goal of treatment of shock is restoration of the cellular and organ perfusion, and the best measure of organ perfusion and best monitor of adequacy of shock therapy is obviously urine output, but the level of consciousness is an important marker of cerebral perfusion but a poor marker of adequacy of resuscitation of shock patients. We must the only clinical indicators of perfusion of the GIT and muscular bed are measurement of lactic acid and mixed venous oxygen saturation. These two are very important. So, besides cardiac output and patient general level of consciousness, other things which are important are lactic acid level in the blood, and if we can measure the mixed venous oxygen saturation, this is a very helpful guide. So, we have to monitor the patients with the help of these parameters. Now, base deficit and lactate, I have already explained that lactic acid is produced as a result of anaerobic respiration and is a sensitive indicator of both the diagnosis of shock and monitoring of response to therapy. So, lactic acid level is very important. We can do ABG, that is arterial blood gas analysis, which can be used to measure these parameters. And now, coming to the mixed venous oxygen saturation, there is a slight spelling mistake over here, SVO2. It is a measure of oxygen saturation in the blood returning to the heart. Long central line is placed in the right atrium of the heart or in the superior vena cava of the heart, from where we can draw the blood and make we can see the mixed venous oxygen saturation. The normal mixed oxygen saturation levels are 50 to 70%, and levels less than 50% indicate inadequate oxygen delivery or increased extraction by cells, which is consistent with hypovolemia. So, less than 50% indicates inadequate oxygen delivery or increased consumption of oxygen by cells, which is in cases of hypovolemia or cardiogenic shock. Levels more than 70% of mixed venous oxygen saturation is seen in cases of sepsis or other distributive shock, where there is disturbed utilization of oxygen at the cellular level, or AV shunting, that is arteriovenous shunting of blood. That is the peripheral oxygen which is being supplied to the peripheral tissues or end organs is not being utilized by them, which is seen in cases of distributive shock or sepsis. Now, the endpoints of resuscitation of shock are patients are usually resuscitated until they have a normal pulse, blood pressure and urine output. So the normal pulse, blood pressure and urine output are very good indicators that the patient is improving, and we can see them clinically. But in many patients, these parameters are normal until late stages of shock. We must be careful about it, and the state of normal vital signs and continued hypoperfusion is called occult hypoperfusion, which if more than 12 hours may lead to increased mortality, which is seen more in cases of younger people with good cardiovascular reserve, and this is obviously a dangerous condition. Resuscitation should be continued until there is correction of global perfusion endpoints, or till the global perfusion endpoints are corrected, rather than the traditional ones. The traditional ones are the BP, urine output and consciousness level. So we should make sure that the patient is out of the base deficit and the lactic acid level. We should measure before stopping any resuscitative measure. Thank you very much.